Now we're going to go to poor response strategies. Those are all our augmentation for partial response. Poor response strategies. Here, you just do the same thing. Check compliance, make sure they're not abusing substance. Go ahead and optimize first. Okay, that is always the thing. Crank the dose, give it a little bit more time, and still, if your poor response is less than 25%, and you probably take it out to 8 weeks, then augmenting is not a good idea, and the best route to go is switching classes. You can kind of assume that we're shooting at the wrong target. Okay? Everybody? Now, within class switches, the main reason for doing this, and what this means is switching from one SSRI to another. The main reason for within class switches is tolerability. Okay, there are just some people. For example, the one that's the worst I've seen happens the most are GI side effects. You know, if somebody is taking SSRIs or they're taking really any of the antidepressants except Wellbutrin, you increase serotonin and you can get diarrhea and gas and stuff like that. So you can try different drugs because they're not all created equal in terms of the side effect profile. Okay. If you've had, I mentioned this before, if you've had 2 failures on SSRIs, then you switch classes. Okay.
So the question.
Yeah.
So that's assuming that you have some positive response with side effects, so you'd stay with that class?
Well, sometimes, okay, maybe. Her question is, assuming you're having some effect. Where you really run into problems, though, is intolerability in the first couple of weeks before there's a chance for the drug to even work. Okay? Let's say you got somebody who has an anxious depression and you based on their past behavior, you're really worried about suicide. That might suggest SSRI, right? So you start with a drug like Paxil, and they get too much something, you know, constipation with Paxil, you can get that, you know, or upset stomach. You probably will get that within the first week or two, and so you could switch to another SSRI even before you know whether it's going to work or not, because they just can't take it. Does that make sense? Okay. Okay, late emerging serotonin side effects. Now, please keep in mind this is not SSRI side effects. It's serotonin side effects. And all of these drugs except Wellbutrin have all the new antidepressants have a significant effect on serotonin. Okay? Sexual dysfunction. This is a really amazing study, in particular because it was so large. Look at this. Look at 6,300 people taking antidepressants, and there's a couple of important take-home points here. First off, they monitored in a number of these people just how many people were coming in complaining of sexual dysfunction, and it was 14%. But if they gave side effect questionnaires to people, 60% of people were saying, I'm having sexual dysfunction side effects. And what that's all about is people feel embarrassed about talking about this. So that's why I think we need to lay the cards on the table and say sexual dysfunction occurs in such and such percentage. Here's the kind of sexual dysfunction that occurs, and for gosh sakes, it's okay to talk about it because if it happens, there are things we can do about it. Okay. Now, my concern is with the ads on TV is they all say can have sexual dysfunction. You know, all the antidepressants. My fantasy, which probably is actually true, is that most men in the country, when they hear that, they think impotency, and a lot of them probably think, I'd rather be depressed, you know. But impotency is not the side effect. Okay. Now, what happened here? It says here, only 29% had no other risk factors except antidepressant exposure. What this means is in this study, they interviewed the patient and they interviewed their significant other. And what they found is something probably not a big surprise. Number one, a lot of these people had sexual dysfunction for a long time, even before they got depressed. The base rates for sexual dysfunction are pretty high in the general population. Okay. Secondly, many of them started having sexual problems once they got depressed. That surprise anybody? Decreased libido. Okay. And only 29% appeared to have what looked like a sexual dysfunction as a side effect when you rule out these other causes of sexual dysfunction. Okay. And the problem is inorgasmia. It's not impotency. It's not failure to lubricate, get aroused, or anything like that. I mean, there's a lot of reasons you can have impotency. You know, performance anxiety, maybe you hate your wife's guts, you know, I mean, stuff like that. But it's not impotency, okay? And actually, I don't have a slide up here, but the current thinking is that what serotonin can do is it causes genital anesthesia. And so the penis and the clitoris do not respond to normal stimulation. Now, one thing you can do is tell people, increase your stimulation. Sometimes that works. Okay, sometimes it works. But here's the main point that I want to make. Now, like Pristique is not up here, although Pristique is actually basically one of the metabolites of Effexor, so probably it's about the same as Effexor. But all of the, and this one is the brand. This is available only generically because it's been associated with some liver problems. But basically, all of these antidepressants, except Wellbutrin, are in this 25 to 30% range. So I think we can say to people with confidence that here's what happened. And I've you know, there's some medical journals you may have seen, like Cosmopolitan magazine, National Enquirer, stuff like that. They say up to 70 or 80% of people taking antidepressants have sexual side effects. Well, that's wrong. You know, if you rule out all these other factors, okay, you say about a quarter to a third of people are going to have sexual side effects. But here's what it is. Okay, it's not impotency, it's not, you can't get aroused, but it's difficult to have an orgasm, and there are treatments for this. Okay. Now, the main sexual effect of Wellbutrin is turning up libido. And some people might say, well, that sounds okay to me. Of course, if you know, you get a parent of an adolescent and they get on the internet, you may say, no. Now, I had two cases, and this is a long time ago, back when I was at Kaiser, and Wellbutrin had come out. And in one case, a woman came in and she was getting a lot better, you know, with her depression. But she said, my husband wanted me to say thank you because the thing is, she, even before she got depressed, she'd had lifelong kind of low sex drive, and actually, she not only got over her depression, but she had increased libido. So that was a good outcome. The other was a woman also who came in, but it caused problems because she actually got more sexually interested. But she and her husband had been quite compatible, both having really low sex drive, and now she's, you know, it sort of destabilized things. So, I mean, that can happen. Could we up the dosage? I still have feelings. And this is serotonin-related side effects, apathy and emotional blunting. Now, you are going to see this. All right. I think I mentioned this in the first class. There's 15 different classes of serotonin receptors. And it looks like 14 of them are inhibitory. Okay? So they shut something down. Now, if you're on longer-term antidepressant treatment, this can occur, and there are not good data on how frequent this is. But this can occur with a minority, but a significant minority of people. And they'll come in and they'll say, otherwise they look like they've been doing really well. They've been on the drug for maybe 9 months or a year. They're saying, you know, I think I'm getting depressed again. So you can have them fill out a depression rating scale, and it looks okay. You think of killing yourself? No. You feel worthless? No. You feel guilty? No. You sleeping okay? Yeah, I'm sleeping okay. And what's happened is this is so gradual that it's imperceptible, but after a period of time, it's a combination of apathy and emotional blunting. And it's, I have it down here, inability to cry. This is really not okay, because what's happening, and there's very good data to support this, okay? This actually was discovered back in the early 90s. But on the surface of many nerve cells in the brain are serotonin receptors, but what's happening here is in the frontal lobes, on dopamine nerve cells, over a period of time, it's inhibiting and dampening. And if you look at PET scans of people that have this, you see decreased metabolic activity in the prefrontal lobes. Take them off the medication, they come back online within a week. Okay? And so this is not irreversible, but it's not okay. And I stopped my practice a number of years ago, but continue to see a few patients, my long-term patients, and one of them, the four people I still see, last year her best friend died, and she thought it was very peculiar that she didn't cry, although she knew it broke her heart that her friend died. And so at some point, a while back, for medical reasons, she went off the antidepressants, and they had been very effective for her. She had really horribly severe chronic PTSD and depression. Went off the antidepressants, and after a week or two, she came in and she says, her friend's name was Shirley. She said, "John, something weird's happened. I was thinking about Shirley the other day, and I just started weeping." No, it's not weird, because it was doing too much of this. It was dampening this, and then also frontal lobes have a lot to do with internally generated motivation to kind of give yourself a jump start and get moving, and people will develop what some of my patients have called sort of a give a shit attitude. They just don't feel fired up about doing stuff. Okay, so this is what some people call poop out. Oh, are these people developing a tolerance for the antidepressant? No, probably not. Almost always it's this. So what do? You reduce the dose, or take them off the drug if it seems prudent to do that. It's probably a good idea to gradually discontinue. Okay. The other thing is you can add a drug that increases dopamine, and that would include things like methamphetamine and cocaine. I don't recommend those. Okay, I don't recommend those. No, I'm joking, but they do activate dopamine. Stimulants do it. All the stimulants like Ritalin and Adderall do it. Problem there is you can't take it in the afternoon because you can't go to sleep. So the best thing to do if they don't respond, well, if you say we can't get them off this or they'll have relapse, is add Wellbutrin, and it'll take 2 or 3 weeks, and then it's like, whoa, I'm coming to life again. Now let me mention one more thing about this, okay, and that is this happens often. People are taking medicine. Let's say they are in the continuation phase for the last 3 months. They haven't had any depression, thank God. But they're being compliant. They're taking the medicine, like the doctor said, for an additional 6 months, and then they run out of the medicine. Okay, and it's like, oops, I've run out of my medicine. Now this would be the case for any of the drugs except Prozac, because remember Prozac stays in your system for a really long time. So what will happen is, let's say it's Friday afternoon and they can't get in touch with their doctor. He or she's out of town or something. Well, I'll get it on Monday. I'm doing okay. And so they go for 24 hours without taking the medication, and probably during that time they don't notice anything. But they go into that next day, and these drugs are pretty rapidly eliminated from the body, and guess what? They start feeling better. And what has happened is, and I'm not talking about the severe emotional blunting, but all the serotonin active drugs, all of them to some degree, do a little bit of blunting. And it's not, maybe that's okay if it is needed to combat severe life-threatening depression, but in the long run, it dampens aliveness. And so so the patient is patient initiated discontinuation because they ran out of medicine. They'll get to Sunday, it's like, not only have I been feeling okay, but actually, I feel better since I stopped this. So they stop it, okay? And then what happens? 4 weeks, 50%. Crash back down into depression. So it's just something to be on the lookout for.